Welcome, everybody. The presenters were just saying that it's very warm outside and sunny, so we didn't know how many we'd get today, but thank you all for joining us. We are on session 9 today, trauma, substance exposure, and language development. And so I'm going to share my screen as Melina gets everyone welcome from the waiting room. So don't forget to chat with your first and last name, your organization, email, and job title. This makes sure that we count you for attendance and helps with our records. Melina, anybody calling in with a phone that we need to call out?
Not yet.
Okay, so we'll keep going. Again, I'm Sue Workman. I'm part of the West Virginia Scope team. Melina is our other team member that helps us with the behind the scenes and IT. We have breakout room facilitators for today. Aisha, Maggie, Cassie, and Mary Beth will be in with our groups, and also Susan. So we are in our home stretch. We have several more sessions left, and we'll be wrapping up cohort 1. As we continue to plan for our sessions, we have session 10, 11, and 12. July 26th, August 16th, and September 13th will be our last session. So we have added this next slide. The Hub planning team had a meeting, and we were talking about the last session. So if you'd like to submit a question, maybe there's a session that you feel like we didn't get long enough to discuss, or you thought of something afterward. So if you'd like to submit a question or even a case that you'd like to be discussed in the breakout rooms, you can follow this link or QR code that's on this slide. We will also share this in the follow-up email, and we will take those and try to have some answers or way to have those for discussion in session 12. We also met with the Scope National Group Planning Group today, and a lot of their groups said that they felt it was very interesting to have peer recovery coaches in on some of the discussions, and also family members. So if you think of someone that might help us out with cohort 2 or this session 12, reach out to Melina and I, and we'll try to add those in and make them part of that conversation. Another note that's a little different this week about evaluations. You might not see that come tonight or tomorrow, so watch for those evaluations later in the week or at the beginning of next week. If you do get concerned and think you might have missed it, let Melina and I know, and we will make sure we get that to you. But just because of schedules, that might be delayed a little bit this week. Okay, so I think we're getting caught up here on everybody getting in from the waiting room. So today we have Mary Beth Mandich and Cassie Miller that will be our presenters for us. And Dr. Mandich is the Vice Dean for Professional Programs in the School of Medicine. She serves as the representative of the Dean of the School of Medicine to numerous education programs throughout the school: athletic training, clinical laboratory science, exercise physiology, health informatics and information management, undergraduate immunology, medical microbiology, occupational therapy, pathologist assistant, and physical therapy. She's a physical therapist by training and serves as a professor and chairperson in the Division of PT. She joined WVU in 1980 and has been in the Dean's office since '93. She holds a bachelor's and master's in physical therapy from Virginia Commonwealth and a PhD in developmental psychology from WVU. Her major area of clinical interest is pediatrics, especially neonatal care and follow-up. She is co-editor of a textbook, Human Development and Performance Across the Lifespan, which is now in its 2nd edition. She continues to be an active teacher in her areas of expertise, including neuroscience and early human development. She continues to practice clinically in high-risk infant care. And with all of that being said, I'm so glad you found time to join us today. Whew, that was a long one. So welcome. Cassie, we're happy to have. You probably recognize her face. She usually facilitates some of our breakout groups and helps on our hub planning team. She serves as the speech language pathologist for the WVU Center for Excellence in Disabilities Feeding and Swallowing Clinic. She's a clinical supervisor for speech pathology graduate students and serves as a member of LIN trainees at the CED. She spent over 10 years providing early intervention services to children in their homes, and she has a special research interest in telehealth and pediatric feeding. So welcome, Mary Beth and Cassie. And I will turn it over to the two of you to begin our didactics. Welcome, everybody, and we'll go ahead and jump in.
Okay, so today Dr. Mandich and I are going to talk about trauma, substance abuse, and language development. So we already talked about us, and we don't have any disclosures to report. Our learning objectives include exploring language development in prenatally exposed children, identify commonly occurring social communication, academic, and executive functioning difficulties for children related to prenatal substance exposure, and increasing awareness of evidence-based interventions and strategies to help support the development of academic and language milestones in children with a history of NAS and NOWS. So first, let's talk a little bit about speech and language and executive functioning, some basic definitions. So receptive language is understanding language, including the semantics or word meanings, and syntax, which is the order of words. Expressive language is language expression or communication, and that could include gestures, verbalizations, using signs, and use of a communication support like PECS, which is picture exchange communication systems, or an AAC device, whether low-tech or high-tech. Social pragmatic language is understanding the social rules of communication, taking turns, staying on topic. Articulation is the production of sounds and words. That's the intelligibility. Fluency is the flow of verbal language. That can include difficulties with stuttering or cluttering or paucity of speech. And then executive functioning that's the thinking skills that we use to manage work and play, activities of daily living. So opioid exposure and language development. Research is limited because there's high attrition rates in study populations. So someone might start the study and then not complete it. And a lot of studies have really small sample sizes, or they rely on caregiver reporting. But what do we know? 14 to 28% of all pregnancies in the US are reported to include some toxic exposure in utero. And often that's of multiple substances, not just one, but it can be some drugs and some alcohol, multiple things. Opioid exposure in utero can also include trauma, some of the ACEs, poverty, and genetics such as ADHD and learning difficulties. What we know about environment and language development, for infants who have been addicted as an infant, and once their withdrawal is over, once they're home, their speech and language can become delayed if the environment is not engaging. For infants who were exposed and they go home with one or both biological parents, language outcomes are worse than those who go home with a foster or adoptive parent. And oftentimes a lack of communicated reciprocity or that predictable interaction between a caregiver and a child can predict future developmental delays. So for a family or a mom and a dad who are struggling with addiction, having consistent interaction can sometimes be difficult.
So the neonatal opioid withdrawal syndrome and neurodevelopment the results are iterative, meaning we are just getting things coming out in the literature from the most recent epidemic of substance abuse with opioids. And it does appear that there are negative effects on the brain. It's important to remember, and Cassie talked about this a little bit in a previous slide, that there are multifactorial issues. And so in some sense, we don't know if it's the drug itself, the drugs do appear to be cleared fairly quickly after the initial neonatal period, or if it is multifactorial, it's more likely the latter. We talked a little bit in previous discussions, and I know you all are, some of you all are right on the front line of this, the turmoil in the environment in these infants. And so the turmoil in the environment may be responsible for some of these negative outcomes. I want to say one other thing about this from a book that I read maybe 8 years ago. It changed my life. The book was called The Anatomy of Violence. And it said that they reported numerous studies from multiple countries that showed that if the baby had 3 factors, negative factors, their predisposition to being arrested for a violent offense in later life was incredibly exacerbated. And those 3 factors were a mild brain injury, as might happen with traumatic, or happen with exposure to substances, lack of a nurturer, which we'll talk about in a minute, and the exposure to the substance. So the brain damage that may come from the substance, the lack of a nurturer, and then also poor nutrition may play a role as well. So go ahead to the next slide. The good news, though, is that our brains are incredibly plastic. You guys know that our brains are not quote unquote mature until about the 25th year of life. And so there is enormous responsivity of the brain for better or for worse. And so back to the studies I was citing about violence in trying to predict violence, they found that all of the negative outcomes could be significantly reduced in the presence of a nurturer. So when we look at the families that we're looking at, if we put them in an environment, whether it's a foster environment, whether it's the biologic parents who are able to be in treatment and be successful and provide that nurturing environment, or whether it's a family member that takes over, the potential to ameliorate or compensate for some of these negative impacts is enormous. And I think that's what our job is in many ways on the front line, is to coach the potential nurturers to provide that environment. Next slide. So I talked a little bit about the maturation of the brain. The frontal lobes, the front part of the brain, is the last to mature. We say last in, first out. So this is like putting the steering wheel on the bus. And you see there the 3 main areas of working memory, inhibitory control, and cognitive flexibility. All of those are heavily related to the ability to be successful in school. Next slide. So working memory you see defined here. But to be able to follow multi-step directions, to take turns, and to participate in reciprocal social interactions. Reciprocity is such an important part of our social environment and our learning environment. But in order to have a reciprocal interaction, you have to be able to understand how to take turns during conversations, and you need to be able to still the background noise in your brain so that you can listen when someone else is talking. And again, those of you in education can relate to that both from the positive and also from the negative, from the kids who can't do that. Next slide, please. Inhibitory control, of course, is the act of being able to think several steps ahead and stop yourself from doing things that might get you in trouble. So as you see here for children, it's waiting their turn, ignoring distractions, and particularly stopping them from acting aggressively towards other children because they can work out that that may have a negative consequence for them in terms of not getting the reward that is embedded in their environment. And if we're looking at positive behavior management. So inhibitory control is really important. And we all know kids who don't have it. They're the ones who are antsy, who jump in, who don't let the teacher or the parent finish what they're going to tell them to do. And so it's incredibly important. Again, another function of that steering wheel that's brought to us by the frontal lobe of the brain. Next slide. And cognitive flexibility, you know, I may be dating myself, but there's an old movie with Dustin Hoffman and Tom Cruise called Rain Man, which is the exact opposite of cognitive flexibility. It shows that perseveration, the inability to switch thoughts from one thing to another, even though Dustin Hoffman, the character, was very intelligent, he couldn't adapt to the changing circumstances. So you see here, this cognitive flexibility allows children to understand there may be different rules in different settings. They may learn specifically for language development exceptions to rules, and we have plenty in the English language. And to understand that there are multiple ways to solve a problem. Next slide. And then social pragmatics, of course, are extremely important in terms of building positive relationships. Initially in that circle of intimacy that is the family, and then as that expands through preschool and school age into age-appropriate interactions with peers. And again, children with neonatal abstinence syndrome or withdrawal syndrome may have difficulty with any of these. And you know, the educators in the group know how easy it is for kids to carry identities with them all the way from preschool and kindergarten into school. So if they start out poorly, it's hard for them sometimes to regroup in terms of these social skills. Okay, next slide. Successful intervention strategies. I'm not going to read all of these, but I would say that the most important thing, as I said at the very beginning of my part, is getting a coach, being a coach to that nurturer. If it's the family, whoever the caregivers are, whoever that person is who's going to provide that environment for the child, that's where we want to focus. And again, we want to focus on reciprocity, what Harvard calls serve and return. I'm going to give you a piece of information. I'm going to say something to you, and like I served a tennis ball, and I expect you to return that to me, and we'll get engaged in this reciprocal interaction. So teaching families to buy into that. And it's easier when there's a match in temperament between the children and the parents, which is one of the barriers we sometimes face in working with these families, is that the parents don't have the capacity to wait or to develop the serve and return. So you really, especially if there's a mismatch in temperament between the child's needs and the parent's abilities, you really have to up your coaching game to get them engaged. Next slide. Now, reading activities are so important. The sound of human language, I have numerous examples. I'll just give you two very quickly. They've started to move to private rooms in neonatal units. And they found that if the parents couldn't room in, some of those babies in those private rooms ended up language delayed. And they believe it was because they didn't hear that normal flow of the human voice or the human language. I have a parent who used to read the Pirate baseball byline out of the Pittsburgh Post-Gazette to that baby, but the baby was hearing the sounds of a human language. Another example I have is in children who are being exposed to bilingual or bilingual exposures. If the bilingual exposure was a tape, an audio tape, it didn't work. It had to be the sound of the human voice. And so you just can't emphasize it enough. And in our environment, again, I always tell the story about being in clinic and saying to the family, do you read? Do you have books? Do you read to him? And one of the parents said to me, I've been thinking about getting one of those. Almost like you would talk about thinking about getting a tricycle. If you want to talk about a nurturing, language-rich environment, that is not a good start if at 1 year of age, they're thinking about getting books. Next slide. So there are lots of community resources for literacy, and I am absolutely a Dolly Parton fan because of her Imagination Library. I'm sure most of you listening know about it. I can't emphasize enough getting families signed up for it because they get it at their house as opposed to the library or the doctor's office where they may have to seek it out. So again, really, really a big fan of what she's done. Next slide. And these literacy tasks can teach functional skills. And there are so many good books out that can encourage the child to interact and develop some of these skills. And always when people are reading, and many of you know this, but asking the child to give you something back, again, that serve and return, will help develop the language development. Like, why is the rainbow fish not giving up his scales? Because he didn't share. But when he shared, he learned that there was such joy in sharing. So again, our role is not to do this so much as to coach parents and for them to understand how important this is for development of language and executive function. So go ahead, Cassie.
So if we identify a child who can use some language intervention, what are some things that the speech language pathologist or the teacher may teach the parent to implement? Teaching new vocabulary, providing a language-rich environment. For my families who are working on language, I always tell them they're the crazy parents at the park that are like, a duck, a yellow duck, the duck is running, a slide, just really iterative and overarching ideas of what's going on in the environment. Choosing meaningful targets. So working on words that the child's going to use a lot. If they love bowling, then talking about bowling. You know, if they have a brother or sister, working on the names of their siblings, things like that. Expanding the complexity of the verbalization. So we might be starting at the sound level and then moving to words and then moving to short phrases. So making sure that we're going to get more complex things as we move on. And then building on what the child says, just like Dr. Mandich talked about, that play back and forth. So if a child comes to you and says, I hurted myself, instead of saying something like, wait, stop, do you mean you hurt yourself? Play back with them. Oh, I see you did hurt yourself. Kind of exaggerating hurt to set the model for the correct word. You know, where did this happen? I can help you. That back and forth play, that reciprocity of communication. Some other interventions for our kiddos who may be struggling with some language skills, articulation therapy. You know, other than just overall intelligibility, it can increase peer interactions. It can build overall self-confidence. Fluency intervention, you know, if there's some stuttering or some prosody difficulties with too quick or too slow speech. And then teaching social pragmatic skills, monitoring their volume, sharing, responding appropriately to social cues. And then sometimes we'll need a compensatory support. So we need a little gap, a little bridge between where the child is functioning and where they need to be to kind of function well in the classroom or at home. So it can be a communication board like you see here, You know, I want, what is it that they want, or what is it that they need? That can decrease frustration. It can really teach functional communication skills. A visual schedule for our kiddos who have anticipatory stress on what's going to happen next, or they have a difficult time kind of following directions. We can also use social stories, right, to really simplify a concept that we need to teach. It can be, I need to sleep in my bed. It can be, don't hit your friends. Using repetition and simplistic structure, we can have the parents implement reading those at home. And then again, it's the give and take. We give them the information, and then the child reciprocates by completing those tasks. So some red flags for referral for language, and we got these from the Boys Town National Research Hospital. By 1 year, I'm not going to read them all, but no babbling, not really imitating anything, limited use of gestures. So when you point, they're not really sure where to look. By 2 years, they're not really attempting to communicate using words, difficulty following directions. Kids should be understood about 50% of the time by age 2. By age 3, it should be about 90%. If at 3, they're frustrated with communication, you know, they're not making attempts, they're throwing themselves on the floor. And then when we get a little bit older, by 4 years, we need to be seeing them using 3-word phrases. They need to be understood most of the time, and they need to be asking WH questions. By 5 years, we need to be telling stories. We need to be using really complex sentences with lots of different word types and different syntaxes. And by the time we're at school age, those, you know, kindergarten, first graders, they're using grammatically correct sentences and not having difficulty with reading and math or following those kind of written directions. So let's move on to our case study. Mary Beth, do you want to introduce our case study?
Sure. So again, this is something that is probably pretty representative. A 6-year-old boy, first grader, and he has a history of the maternal substance abuse and that tumultuous living situation that we described. The grandparents are currently, paternal grandparents are currently the stable figures. The child is in school in a regular ed class, but he's not meeting grade level milestones for reading. He has limited phonemic awareness, and he just has trouble making friends. Like, he wants to run up to kids on the playground. He wants them to play with him, but partly because he has that poor executive function, he's not a very pleasant kid to play with. And so they end up not sustaining interaction with him. And so he doesn't get those cues that his lack of impulse control, etc., is causing him difficulty in finding kids to play with. His speech is often difficult to understand, and the more upset he gets, the more difficult it is. And then he often runs to the teachers and says he can't get anybody to play with him. So then he gets a further reputation of just always trying to run and tattle on the other kids. So he's still young. It's early days yet, but you know, clearly this is not on a good path. So we have some leading questions for you to consider. Cassie, you want to do the questions?
Sure. So for our first group, what resources can be implemented at school and or at home to help this child achieve grade level academic mastery? The second is to identify why this child is struggling with peer interactions and what supports and strategies can be used to support social emotional development. And the third, what speech and language difficulties can you identify within this child's classroom interactions? How can we intervene and make them more successful with peers and within that classroom environment? Sue, do we want to do 3 groups or more?
Yeah, I agree with Melina. Probably 3 today, Cassie.
Perfect.
Mm-hmm. All right. Okay, Cassie, I'm going to throw it back over to you so you can get your report outs here.
Perfect. Okay, so who had question 1 about what resources we can implement at school or home to help achieve grade level academic mastery. Anyone want to raise their little hand and report out? Anyone work on question 1? I'll have awkward silence. Melina, who was facilitator for group 1?
Aisha.
Aisha.
I'm sorry. So we came up with like evaluation of hearing and speech production, the need for IEP, screening development, and seeing if there's any other milestones that needed to be met, that have were not being met, and how was the child's overall growth and health. And then also like looking at medical history and if there are any frequent ear infections as a child, or if the child is an only child.
Perfect. Dr. Mandich, did you have anything to add on that one about resources that you could see being implemented?
No, I think that's good.
Yeah, I think that first question can help set the stage for gathering more information, right? So we can get the strengths and weaknesses of that kiddo, and we can decide really where we need to dig in, if we need IEP, if we need, more thorough diagnostic testing. Good. Okay, number 2, identify why this child is struggling with peer interactions. What supports and strategies can be used to support social emotional development? And I believe, Susan, you're facilitator for question 2.
Yeah, so we had a awesome group and lots of participants, and my fingers were going as fast as possible to type it all up. So this is what our group has come up with. Very basically, we're looking at a child that has, some inconsistency within his biological family, his kinship placements, and he's having trouble with communication. And so when we looked at then the bulk of our question, what supports and strategies can be used to identify social-emotional development, we came up with this list. We want to create safe space and positive learning environments. We need a teacher who will be a leader in the classroom for the peers and how to interact with him. We want to find a peer who's good at interactions with him. We want to find commonalities within the classroom. We might use social stories for peer interaction. We'd like to see a thorough assessment done to work on that IEP. And even if that IEP might just be speech related, we wanted to make sure he had that support built in. We recognize that he needs friends and supports and successful interactions. So we want to enroll him into some type of sports or activities, like taking him to the pool, where we can target activities that don't need communication. Learning through play, and we recognize we might need to teach him how to interact and play with children. We may need to work with his peers on being understanding of a child with his needs. We also want to dig into his history a little bit. We want to find out about the lack of peer relationships. Maybe that his first few years he really didn't interact with peers. Maybe it was mostly with the adults in his family system. We know we can use games or computers to build competency in his speech. And then an important piece that we talked about was working with the family to promote positive interactions. This is going to be supporting those grandparents through programs like Grand Families. We want to figure out what skills do the grandparents have, what skills do they lack. We want to teach them about the why he's acting this way without blaming, but give them some education about early years and development. So that was our group in a nutshell.
Okay, excellent. Thank you. Let's do number 3, and we'll go back and see if anyone else has anything to add kind of across the board. So what speech and language difficulties can you identify within this child's classroom interactions, and how can we intervene? Dr. James, I believe you're that facilitator. You're on mute.
I
Yeah.
know. It takes a little while for me
Okay.
to mute. So, so we had a good discussion, and we, as we looked at the different difficulties that the child had, we found that many of those that you listed as areas of difficulty this child had. The kinds of things that we talked about was suggested Title I reading specialist could be a person that would be instrumental in helping the child in the classroom, and that person as well would be one who could send activities home for the grandparents to do. We talked about speech and occupational therapy, whether it's in school or outside, and the benefits of that would be is that there could be sessions in which it might be the child by themselves, but there also would be sessions in which potentially the child would be working with another child, and then through that be able to work on that communication, as well as other interactions, social interactions. Getting the father more involved, since the father was in the home, and finding ways that the child and the father could interact. So sending home things from school for the child to tell the father about, and encouraging the father to interact, and talked about having opportunities for playing with sounds and games, and songs. And as we were ending it, Mary Beth was talking about mindfulness as a strategy, and we mid-sentence got switched off. And I don't know if this is something you were going to talk about when you two were talking, but I thought it was pretty interesting. So if we could get Mary Beth to talk a little bit about that.
Yeah, you know that there's a lot of work with age-appropriate mindfulness strategies, and I was just giving the example from Daniel Tiger for the preschool set, where if you're upset and want to roar, take a deep breath and count to 4. So this is not like what you would do in the adult ones, but it's age appropriate, and it can help children, you know, take a deep breath, count to 4, reset, and to maybe de-escalate some of the social interactions. So again, don't forget, the evidence for mindfulness is just really strong, even in school age kids. And so you could age appropriately maybe do some things with him to help him with impulse control and some of those interactions.
I really like that. It's interesting too. I think a lot of the cases we've talked about prior to this were younger kids that, you know, are in early intervention, and this is a school-aged child. So I think those were a little bit different strategies that we would need to implement. Anything else that anyone thought of or noticed or wanted to comment on, an experience that you've had, a child that you have worked with, or a story? I'm going to put, oh, go ahead, Susan.
I was just going to chime in and say, you know, just from my personal experiences, that age is the perfect time frame to help, you know, the entire classroom really get to understand how to work with a child with special needs, or, you know, that might act differently than some of the other kids, and just to create tolerance in the classroom. I know my son had a child in their classroom, and they did a lot of work with their guidance counselor on being inclusive and kind, and smaller breakouts. They found kids who, you know, the kid that couldn't sit still in their seat and wanted to help everybody, and just really paired people up. And I think my group did a nice job of talking about that, but it just made me think about, you know, it is the perfect age for us to to really work with the other kids in the classroom for developing tolerance.
Yeah. And I think Dr. Romano and Dr. James both see kids this age in their practices. So how do you see parents responding when their kids are coming home with kind of these kind of reports? Do you have any insight into what we can do to help reach those parents from seeing these kiddos in your practices?
I think the important thing is to find out where the parent is. And most of the time when the child is having difficulties like this, it's not a surprise to the parents. And in this case, I'm sure it's not a surprise to the grandparents. What is often very hurtful for them, though, is to have this elucidated and to have it discussed and kind of brought out, you know. But families, in my experience, have been so willing to look at this. If you start with that evaluation, like we talked about in our group, and the family sees that people are not just saying this is a problem, they're saying, let's find out what the problem is, and let's find out what the steps are that we can take to address this problem. And a lot of these things that people have come up with are low tech. They're easy to do, and they're very, very effective. And it's in my experience, and Maggie can chime in too, just a little bit of a positive response goes a very, very long way.
Mm-hmm. And I think, you know, one of the things is often, you know, I sometimes see families in which what gets sent home from school is always negative. And so I, you know, always encourage that something positive be sent home. Because every child has something positive about them. And parents and children get distressed when all they hear is negative. And I think children then begin to believe that about themselves. And then you have two things that you have to overcome. You know, how they feel about themselves. So encouraging things as not problems, they're opportunities. And encouraging positivity as well.
And Melinda, not to put you on the spot, but I know you've worked with families for many years in their homes too. Have you seen more successful strategies for getting families on board? Melinda Graham, let's see if she's still there.
Yeah, I'm here. Of course, so many of the strategies that were talked about today are things that our speech and language pathologists talk about often. I mean, the Dolly Parton Imagination Library was mentioned, and that's something that I share with all of our families. But we do have a lot of grandparents that are providing home and care for grandchildren. And I do think that is a challenge. And some of them are not young. Some of them actually have had some great grandparents. Mm-hmm. So it's difficult. And then when there are some behavior issues, it's very difficult for grandparents. I think they just don't have the energy to sometimes deal with all that.
And sometimes they may want to just be their grandparent and give their grandkid an ice cream cone. You know, they take on all these roles. We talk about, you know, when there's a child with high level needs, the parent becomes the nurse and the therapist and all those things. In this case, the, you know, grandparent is becoming the teacher and the disciplinarian and, you know, all those different roles. So,
right.
Yeah. Thank you for that insight.
And I think something else we might want to just bring up too, not in a negative sense with the grandparents, but you get the impression that the grandparents are very dismissive of the biologic mother. And, you know, that there has been several episodes where there's been a trial of reunification and it hasn't worked. Well, you know, that in and of itself, my goodness, it's hard to tell, what has happened during those periods of time. Was the child back with the mother, and did it actually fail? So that there's probably a lot of stuff under there. And then, if the little boy hears or at least feels that negative energy, directed towards his mother, that could really, really be a source of the child's own distress. So, it's not really our job to go in and do therapy like that, but some of these other suggestions, like the I always mispronounce it, the grandparents group, those kind of emotional supports might help.
I've also found that in my teaching years, a lot of times parents, when they're very open to you coming into the home, and instead of getting all this information written out, come and show me. So you can always offer to say, well, I can show you this and how we're doing it at school if you want. And again, we don't know the grandparents' educational level. They've not been trained to be interventionists. So they might be very welcoming to have you come in and show how you might help the child with phonemic awareness games. Or when a child is demonstrating this type of behavior, what they might be able to do. And then it's their choice whether they do it. But for some of us, seeing is much easier to learn from than reading.
I love that, Colleen. I think we're making a big assumption by saying that in an IEP meeting or in one meeting, these grandparents are going to be able to assimilate all this information and then generalize it to home and implement it. So I love the idea of, even asking them, how do you learn best? How can we support you in doing that? Thank you for bringing that up. Does anyone else have any experience with kind of expanding that? Gina, did you have something?
Yeah, actually, can you hear me?
Yes.
Okay. I was going to say, I don't know what the communication would be between the school and the home on a daily basis, because I know when my kids are in school, I don't know what goes on, and if kids are coming home on a bus, there's no way to really know from a professional or from an adult what went on with my child at school. And if that child isn't someone you interact with kind of in a mature way, and you're just parenting them and they're misbehaving already and they're just the kid at home, you don't really ask them, what kind of day did you have? How did you play? And so the artwork could be a bridge between school and home, because if they use that, you can look at that drawing and you can tell the mood of a child just by the way they draw or the way they create their art. And then you can get into conversation like, what does that mean? What did you draw over there? And sometimes that's how I found out that my kids were in a bad mood, because the artwork was dark. Oh, that boy is kicking the other kid or something like that. And then you're saying, well, why? So to have some kind of bridge to get that daily communication going, like, how was your day? What did you do? Show me what you drew today. To give a bridge, because I don't know that just getting dropped off on a bus is going to give that family any feedback about how the day was.
I love that idea of taking out the part that's hard for language and letting them express art how they want, and then tease out those pieces. That's a great idea, Gina. Thank you. Anyone else have any ideas on how to increase communication between the school and the family? And I'm not as familiar with the school system, so does anybody know how those kind of avenues work?
My friend is autistic and had some behavior issues, and I believe put in his IEP for a daily communication log with the teacher. Now, I think you would have to request that. It's extra work for the teachers, and yeah, that was in place, I believe, in his IEP.
Perfect. That's a great idea. And Dr. Romano talked about not relating everything to the NAS, but more to the behaviors that are occurring to reduce that stigma surrounding that diagnosis. And I think then we also pull back away from the blame game of, if there's already a tense relationship with mom, then we're not constantly, iteratively going back to that. Yeah. Anyone else have anything to add to this discussion? Thank you all for joining in. I love when everyone can collaboratively kind of talk about these things. An experience or something that you're like, oh, this worked really well for me, or this failed miserably.
I think it's 100% in how we present things. Well, I should say probably 99% of how we present it and 1% the actual presentation. Like I know that there's like specific home visitors or parenting providers that I work with that are just better at kind of the methods of communication than others. And you know, when I know it's a especially like a grandparent who's going to have a difficult time receiving the information, I want to go after, you know, requesting that provider that I know can twist the way she's presenting the idea of coming into the home and doing parenting. One time I had a grandparent say, I've raised, this is like my third generation of children that I've raised. I surely do not need parenting classes. And, you know, they were like, oh, no, this isn't about parenting classes. This is about, you know, this child and working with, you know, I forget how they worded it, but it was like more about it's the child and he's, you know, he's difficult. And this is about helping the school communicating and him with his peers. It wasn't, even though really what we wanted to work on was the way that the grandparents were this was a child abuse and neglect case, but how the parents were penalizing the child for behaviors in the school, which were directly related to kind of the same situations, lack of communication, lack of peer interactions, and, you know, the childhood trauma that was happening. So anyway, all I was going to say was just, I think how we present our interventions are really important.
Thank you for bringing that up. I think that matches kind of what Dr. Mandich was talking about mindfulness and just we as practitioners, you know, figuring out where to situate ourselves to best meet the needs of our families. And sometimes that's stepping away from the expert role and learning where to kind of situate yourself to present that information. Thank you, Susan, for bringing that up.
I tell all of my students as they come through my courses that at IEP meetings or any type of parent interaction, you watch how you phrase things and you think how you would feel if someone was telling you what you're telling a parent about their child. They were saying it in the same way to you, because there are ways to say things. Oh, had some difficulty today with getting along with peers, rather, oh, we had a horrible time playing with others. Whereas you're letting them know that there is that concern, but it's in a way where the parent can be more accepting of it, because chances are they've noticed that. And I also, before my IEP meetings and everything, I would send home to the parents, what things are you seeing in reading at home? What about math? Are there any areas of difficulty? And I think if we send that home, if we are teaching or working with parents and saying, are there any areas you're having difficulty with? Would you like to work together on them? Kind of gives the parent that choice. And I think when we give that choice versus forcing ourselves on them, we find that parents might be more accepting of any assistance.
Good. Thank you, Colleen.
I just wanted to say that we talked about and chose a child who was a little bit older, I think, to really show, you know, the snowball starting to roll down the hill here. And there's some urgency to interventions. And so all of the things that people have suggested and the comments they made and hopefully the passion of the teacher and the reading specialists, etc., will create an intervention plan that will turn this around a little bit, because you can see how this can go very negatively if there's not an attempt here to try and address this. Because as you point out, the one-on-one interactions with teachers and stuff, those become less and less the older the child gets. And so I think there is some urgency to the case, and I think it would be really important to try that people would feel that and try and implement all of these suggestions.
Dr. Manders, can you talk about some of the implications that you would be aware of that may happen with this kiddo if we're not catching these things now, if we kind of you know, don't catch that IEP and don't get that Title I educator in there? What can you see kind of snowballing if we don't catch these things now?
Well, I think the number one thing is failure, right? Is just not having any sense of efficacy about his performance, and so that sense of failure breeds, if you have nothing left to gain, you don't really invest yourself in trying to improve. And so that happens very early on, these early elementary grades. And so I think letting this child experience social success, academic success, those kinds of things will be incredibly important. And frankly, will be incredibly rewarding to watch if they can be experienced.
Perfect. Thank you, Dr. Mandich. Anybody have another thing before we turn it over to Melina and Sue? Okay, I think we're turning it back over. High five. Mary Beth, we did it. Boom.
Thank you both. I think it was a really good discussion today. Thank you all for, turning your cameras on and joining us. It's good to see everybody's faces and hear the different perspectives. And Melina and I aren't always in the breakout room, so it's nice to hear the report out this way. To follow up on this session, our next session is trauma, substance exposure, and sensory concerns. So today we talked a little bit more about the speech and language aspect, but next time on July 26th, it will be the sensory concerns. So we're looking forward to that. We tried to put some of the links to the resources that were mentioned in the chat. So some of those are there if you want to see them. Melina even found the Daniel Tiger video. So thank you, Mary Beth, for that resource. You can always reach out to us if you can't find them. And Melina also put a note to please remember to submit your other questions or cases for session 12. That one's not till September, so you have a little bit of time, but we do have a link there that you can fill out, put your information in there, and we can always follow up with you to get more information. So again, thank you for joining us. The evaluations will be coming. Again, may not be tonight or tomorrow, but look for those to come. If you're having any trouble with your credits or certificates, let us know. We'll continue to follow up on those. Otherwise, thank you all and have a good rest of the day.